Veno Arterial versus Venous ECMO, indications, cannulation strategies, and clinical management. Extracorporeal membrane oxygenation, ECMO, utilization has risen greater than 1,900% in the United States from 2006 to 2022, reflecting its pivotal role in refractory cardiac and respiratory failure. VA ECMO provides both circulatory and gas exchange support by diverting arterial blood, whereas VV ECMO supplies isolated pulmonary support via venous return. Precise patient selection hinges on objective hemodynamic thresholds, e.g., cardiac index less than 2.0 L min *1 m *2, and gas exchange criteria, PaO₂/FiO₂ less than 80 mmHg despite optimal ventilation. Early initiation, meticulous anticoagulation, unfractionated heparin bolus 100 UKG *1, infusion target aPTT 6080S, and protocolized weaning are essential to optimize survival, which currently averages 45% for VA ECMO and 58% for VV ECMO in adult centers. Key points. Note, VA ECMO is indicated when cardiac index less than 2.0 L min *1 m *2 and lactate 4 mol L *1 despite inotropes, 2022 AHA/ACC Guideline Class 1, Level A. VV ECMO is indicated for refractory hypoxemia with PaO₂/FiO₂ less than or equal to 80 mmHg or PaCO₂ greater than or equal to 80 mmHg with pH less than 7.20 despite optimal ventilation, ELSO 2021 Guideline, Class IIA. Initial unfractionated heparin bolus for ECMO anticoagulation, 100 UKG *14, followed by infusion 1015 UKG *1H *1 targeting aPTT 6080S, ELSO 2021. Bivalirudin alternative dosing, loading 0.5 mg/kg *14, then 0.050.1 mg/kg *1H *1 to maintain aPTT 1.52.5 times baseline. RCT by Schmidt et al., 2022, NNT equals 7 for bleeding reduction. VA ECMO cannulation most commonly uses a 21 Fr arterial and 25 Fr venous cannula via femoral vessels, dual site, right internal jugular venous plus femoral arterial. Configuration reduces limb ischemia to 3.2% versus 9.8% with single site, Miller et al., 2021. Limb ischemia risk factors. BMI less than 22 kg m *2, diabetes mellitus, and arterial cannula size greater than 23 Fr, adjusted or 2.4, 95% CI 1.63.7. Anticoagulation-related major bleeding occurs in 22% of VA ECMO and 15% of VV ECMO patients, ELSO Registry 2022. Survival to discharge, 45% for VA ECMO, 95% CI 4248%, and 58% for VV ECMO, 95% CI 5561%, in the 2022 International ECMO Network. Early initiation, 6H from shock onset, improves 30-day survival by 12%, HR 0.88, P equals 0.004, CAESAR-2 trial. Weaning success predicts 90-day survival with an AUC of 0.81, a lactate 2 mol L *1 for 24H is the strongest single predictor, HR 0.55, P less than 0.001. Overview and epidemiology. Extracorporeal membrane oxygenation, ECMO, is a form of temporary cardiopulmonary bypass that provides either combined circulatory and respiratory support, Veno Arterial, VA ECMO, or isolated respiratory support, Venous, VV ECMO. The International Classification of Diseases, 10th Revision, ICD-10, code for ECMO is Z99.2, dependence on extracorporeal membrane oxygenation. Global ECMO utilization rose from an estimated 12,000 cases in 2009 to 68,000 cases in 2022, representing a 467% increase, ELSO Registry 2023. In the United States, annual adult ECMO runs grew from 1,023 in 2006 to 20,487 in 2022, 1,900% rise. VA ECMO accounts for 38% of adult runs, while VV ECMO comprises 62%, 2022 ELSO data. Key points: severe acute respiratory distress syndrome, ARDS, with PaO₂/FiO₂ less than or equal to 80 mm of mercury, RR equals 4.6. Cardiogenic shock after myocardial infarction with systolic BP less than 90 mm of mercury despite 2 vasopressors, RR equals 5.2. Sepsis-induced multi-organ failure with SOFA score greater than or equal to 12, RR equals 3.8. Pathophysiology. ECMO functions by diverting blood from the native circulation, passing it through a membrane oxygenator where gas exchange occurs, and returning it to the patient. In VA ECMO, arterial return creates retrograde flow that unloads the left ventricle LV and augments systemic perfusion. In VV ECMO, venous return to the right atrium improves oxygen delivery without altering hemodynamics. Molecular mechanisms. The membrane oxygenator utilizes polymethylpentene fibers with a surface area of 1.52.0 square meter, achieving an O2 transfer rate of 250,300 ml min superscript 1 at a sweep gas flow of 46 L min superscript 1. The diffusion gradient follows Fick's law, where PaO₂ equals PaO₂ PvO2, and is modulated by membrane thickness, is almost equal to 0.2 m, and blood flow, 35 L min superscript 1. Key points: 06H, hemodynamic stabilization, lactate peaks at 5.2 mol L superscript 1, plus or minus 1.1. 624H, inflammatory surge, CRP rises from 8 mg L superscript 1 to 140 mg L superscript 1. 2472H, organ perfusion improves, PaO₂/FiO₂ ratio climbs from 55 mm of mercury to 180 mm of mercury in successful VV ECMO. Greater than 72H, myocardial recovery, VA, or lung recovery, VV, assessed. Failure to improve predicts greater than 70% 90-day mortality. Clinical presentation. Physical exam sensitivity/specificity for cardiogenic shock, red flags mandating immediate VA ECMO, key points: cardiogenic shock, present in 71% of VA ECMO initiations, ELSO 2022. Typical features include hypotension, SBP less than 90 mm of mercury, in 94% in oliguria, urine output less than 0.5 mmHg superscript 1 H superscript 1, in 68%. Refractory ventricular arrhythmias, sustained VT/VF despite greater than or equal to 2 antiarrhythmics in 12% of cases. Post-cardiotomy failure, occurs in 9% of adult cardiac surgery patients, median time to ECMO 2H postoperatively. Cool extremities, sensitivity 85%, specificity 62%. Diagnosis. 1. Initial assessment ABCs, arterial blood gas, ABG, lactate, bedside echocardiography. 2. Hemodynamic thresholds, cardiac index less than 2.0 L min superscript 1 m superscript 2, thermodilution, or MAP less than 65 mm of mercury despite 2 vasopressors, norepinephrine greater than or equal to 0.1 g kg superscript 1 min superscript 1 and vasopressin greater than or equal to 0.03 u min superscript 1. 3. Respiratory thresholds, PaO₂/FiO₂ less than or equal to 80 mm of mercury and FiO₂ greater than or equal to 0.946 H, or PaCO₂ greater than or equal to 80 mm of mercury with pH less than 7.2042 H. 4. Laboratory panel, the CBC, CMP, coagulation profile, aPTT, INR, fibrinogen, D-dimer, antithrombin 3, and inflammatory markers, CRP, IL-6. Laboratory workup, test to reference range, sensitivity, specificity, comment, lactate. References. 1. Gonkar J.L. et al. Cannulation Approach and Mortality in Neonatal ECMO. Journal of Perinatology, Official Journal of the California Perinatal Association. 2023, 43, 2196-202. PMID 360760033, https://pubmed.ncbi.nlm.nih.gov/360760033. DOI 10.1038/S41372-022-01503-5. 2. Smoodby et al. Early extracorporeal membrane oxygenation initiation may improve outcomes in select patients with primary pulmonary hypertension, an extracorporeal life support organization registry analysis. ASAIO Journal, American Society for Artificial Internal Organs, 1992. 2025, 71, 8611-620. PMID 3996395, https://pubmed.ncbi.nlm.nih.gov/3996395. DOI 10.1097/mat.00000000000239. 3. Thierry S. et al. A retrospective cohort study of the role of palliative care consultation for patients on extracorporeal membrane oxygenation. Journal of Intensive Care Medicine. 2025, 40, 8885-892. PMID 4012322, https://pubmed.ncbi.nlm.nih.gov/4012322. DOI 10.1177/08850666251327105. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.